Any questions I can answer before we get started? Anything from the quiz you were like, what the heck was that? That was pretty straightforward for the most part, yeah. Was it too distracting having the extra distractors on the matching? Yeah, right. So again, if you knew it, you knew it.
Yeah, pretty much.
Exactly, right. So if you didn't know it, then you're like, I don't know, I'm just going to pick a random one out of the list and we'll see. But anywho, so getting into, we're going to finish up our talk on pain management, getting into the rheumatology stuff. And so basically the test is going to end, the way I've got it set up right now, it's going to basically go through behavioral up through the antidepressants, and then we'll cover the rest of behavioral stuff on the next test. Okay, so we'll see how far I get through all that material, but that should be where the test kind of ends at, as it currently stands. Okay. So anyways, we're talking about pain management. We talked a lot about our opioids. We talked about, you know, the common side effects you're going to see with that, how they work, why they work, etc. We have other medications that can help us out as well, right? Because does every pain problem need to be treated with opioids? Absolutely not, right? There's lots of adjuvant medications we can use here, and that's what we're going to talk about right now. Big thing you're going to find is that neuropathic pain, things like diabetic neuropathies, things like maybe MS, or things where, say for instance, you have chemotherapy-induced neuropathies. These are treated better with some of these adjuvant medications here. So this is where things like anticonvulsants, which we're going to talk about more in the neuro section later on. This is where things like lidocaine, which can be a transdermal or a topical product, can be useful. Lidocaine is what type of drug? Anyone know? Called a local anesthetic, yeah, because we're working locally, right, to get its, and we'll talk about the mechanisms later on. And then things like tricyclic antidepressants, which we'll talk about in the behavioral section under the antidepressants. That's kind of one of your older class of drugs used for depression. We don't use it as much for depression now. Nowadays, it's more seen for things like sleep or things like neuropathic pain management there. And you're going to find that a lot of people are going to respond very differently depending on the class of medication they get. Some people just respond better to one versus another. I wish I had a crystal ball to tell you, oh yeah, this person is going to really respond well to this. Oftentimes we just don't know. Okay, so this is where things, as I mentioned a few of these already, you know, think about what the etiology of the pain is. If it's a lot of muscle spasms causing the pain, well, let's give them a muscle relaxant, right? You know, we'll talk about some of these other agents here. You know, things like botulinum toxins. What does Botox do? Paralyzes muscles, and it doesn't relax it, it paralyzes it, right? Keeps it from contracting. So that could be really good for patients who have maybe a very significant contractures. You know, we use a lot of Botox over at Nemours, and you're like, well, I mean, most of those kids shouldn't have wrinkles yet, right? They don't, but if you have things like CP and they have very significant spasticity, like we can inject those muscles and relax that. And again, if you imagine kind of over contracting your muscles, how that's painful, they live with that, right? So that's why a lot of these medications can be very useful. So we'll talk about some of these going forward. Antiepileptics, we're going to get into their mechanism more in the neurology section. Just know that they are also used as adjuvants for pain management here. So things like carbamazepine, things like gabapentin, lamotrigine. We'll talk much more about these later, but just know that they're used here. Typically, what we're going to do with a lot of these drugs, and one of the things you'll see with antiepileptics, they actually kind of work a lot of times similar to the antiarrhythmics. And what do we do with a lot of antiarrhythmic drugs? We slow down conduction, right? We do the same thing in the brain for antiepileptics. We're slowing down the speed of conduction. So as you'll see with a lot of those drugs, mental slowing is one of the big side effects, right? You're going to see sedation, you're going to see ataxia, nystagmus, those sorts of things. So you really want to start low and go slow with these, right? And again, you can probably say that about any class of drugs, but certainly for these as well. You can always give more. You don't want to kind of hit them full court blast, because then they're going to be zonked out. They're not going to be able to participate in life for the most part. So those are big things to watch out for. Again, it's going to vary depending on the drug, and we'll talk more about those you know, unique points when we get to that in the neurology section later on. Tricyclic antidepressants, oftentimes they're considered to be sort of a gold standard sort of medication when used for neuropathic pain management. We'll talk more about these in the behavioral section probably next week when we get to that. But there's a lot of side effects associated with them, right? They have a strong anticholinergic profile to them. And what side effects do you see with that? Dry as a bone, mad as a hatter, all of that, right? So you know the anticholinergic side effects, right? You also can see things like cardiac abnormalities. One of the big things you'll see with all antidepressants, they can cause sexual dysfunction, right? So again, that could be problematic. The patient has neuropathic pain issues, and all of a sudden they have sexual dysfunction on top of it. It can be problematic, right? So things like that we're going to be watching for, and we'll talk about these. The big reason why we think they work is because they're blocking the reuptake of norepinephrine, and by activating some of those norepinephrine receptors, specifically like in the spinal cord, we think that kind of helps to dull that response to that neuropathic pain. So that's kind of the way that we think it works. We don't really know the full mechanism, but that's what we think. We know if we give these meds, these patients, it typically works. And then local anesthetics are actually being used quite frequently now, because these have been found, especially in the post-operative setting, to be really effective at reducing the amount of opioids patients are receiving. So I was talking about things like local blocks or caudal blocks and things like that. So depending on where you send the local anesthetic, basically you're shutting off all signal transmission from those nerves ever making up to the brain, right? So does anyone ever like receive an anesthetic and how it feels? Like, it feels kind of funny, right? Because again, you know that you're being touched in a certain area, but you just can't. You maybe feel some pressure, but you really don't experience any of those sensations associated with that. So the way they're working is by basically just to shut off the propagation of that action potential up to the brain, and it does that by blocking sodium channels. And so we talked about lidocaine before as being a local anesthetic. Where do we see lidocaine before? And cardiac as an antiarrhythmic, right? Anyone remember the classification for it? It's 1B is 1B antiarrhythmic, right? It works better in ischemic tissue. That's why we liked it in MI. It works as a local anesthetic by blocking sodium channels on these neurons, not just in the heart. And so by blocking that propagation of the action potential, the signal never makes it up to the brain. So we use it quite frequently, as I mentioned, in those local blocks, regional blocks. Other ones we use quite frequently include things like ropivacaine and bupivacaine. So if you ever see someone like going into labor getting an epidural, usually it's fentanyl, which is an opioid, plus ropivacaine. It's a very common epidural combination there. And again, by applying it directly into the spinal cord, and depending on the level of where that drug reaches up to, you'll find that you can get good local anesthesia for only certain parts of the body. So for instance, when you're, and anyone who's been party to someone going through labor, you'll see that based on their positioning, you can actually affect how high the drug is actually reaching up in the spinal cord and how much numbing effect they're going to get. So for instance, with someone who's going through labor, do you want them to be numb all the way up through their entire body? No, you want them to basically be deadening that sensation basically from kind of waist down, essentially, right? Because again, that's where a lot of that pain's coming through. But also you have to think about, well, how much am I deadening that sensation? Because additionally, when you're having someone going through vaginal birth, you need them to do what? To push, and if you deaden that feeling too much, they may not even realize that they have that urge to push, and so that can sometimes prolong the actual labor time there. So things to consider, right? Other things, we use a lot of topical agents that are good for helping to numb up areas where you're, say, doing a procedure. So say if you're performing a suturing for a laceration, or say you're trying to get an IV site performed, and maybe you have someone who's a little needle phobic, they're worried about pain. This is where things like lidocaine can be used here. We have one called IMLA cream. Basically, IMLA stands for a eutectic mixture of local anesthetics. Again, it's just more of a trivia point than anything else, but it's a mixture of lidocaine and prilocaine mixing together. You apply it topically. And a lot of times we have patients who have ports and things like that. We'll tell them before they come into the ER, before they come into the infusion center, just apply that IMLA cream right to the port site. And that way, by the time they come in, it's already numbed up, and they can get their port accessed and do whatever they need to do, right? 'Cause it takes some time to kick in. But lots of options for local anesthetics. Lidoderm patches are also used quite frequently for things like post-herpetic neuralgias, etc. So any kind of neuropathic pain, local anesthetics can be very good for that. Going to the skeletal muscle relaxants, these are commonly prescribed along with things like anti-inflammatories like NSAIDs, are prescribed along with opioids. So we have several in this category, things like baclofen, we have cyclobenzaprine, metaxalone, methocarbamol, and then tizanidine. Okay, and you probably have heard some of these brand names before. Someone who's maybe had an injury and they got put on one of these muscle relaxants. Now, it would be ideal if we could just directly relax the particular muscles that are painful, but we can't really do that with these systemic acting meds. So what they're doing is working centrally on the GABA B receptors. Now, we talked about GABA A before. I mentioned it briefly. We'll talk a lot about it during the neurology section and when we talk about things like anxiety and whatnot in the behavioral section. But GABA A is typically used to kind of slow down and break the entire system in the brain, right? That slows everything down. GABA B is a little bit more specialized and is useful for causing skeletal muscle contractions. By giving these medications that agonize GABA B, they're activating them. They typically cause skeletal muscle relaxation. They kind of increase that chloride flow in, and they allow for the muscle cells to hyperpolarize and become less likely to fire off, and so you get relaxation of the muscles. That makes sense? So when you're activating GABA B, it's inhibitory. You open up that channel, chloride flows in, it's hyperpolarizing the cells. So good for pain states involving muscle spasm. We use methocarbamol actually all the time in some of our kids who are getting spinal surgery. If you imagine if you're going through spinal surgery, it's a very painful procedure when they come out. So imagine if you're straightening out a kid's spine who suffer from significant scoliosis. You don't want those muscles to contract and try to kind of monkey with all that straightening out that you did. So we put them on methocarbamol, and it helps to prevent them from having those muscle contractures, and helps to relieve some pain, helps to keep things nice and steady, so that way they can heal up and eventually get discharged, right? So we use these all the time. And again, if you think about it, like if you have a painful, say, limb, something like that, pain, what do you normally do if you experience pain? Normally you want to get away from that pain. You retract, right? So you cause a spasm, and guess what that muscle then does? Causes more pain, right? So again, sometimes using these muscle relaxants can interrupt that cycle, and that can be useful, right? So these are good synergy. They can add synergy to other medications like opioids or like NSAIDs and things like that. However, they cause a lot of drowsiness, they cause a lot of sedation. And so what other class of drugs do we talk about for pain that causes a lot of drowsiness and sedation? Opioids, right? So this is a very common combination. I see a lot of patients either inadvertently or intentionally overdose on when they're taking these along with opioids. And so they end up in the ER because they were found down at home, unconscious sometimes, or very difficult to arouse, and they have to come in and get managed by us, right? And opioids, it's nice and easy to reverse, right? What can I give them? Narcan. Is there any reversal agents for this? No, there's not. Only the tincture of time, right? You have to give them time to metabolize the drug off. So we always talk about, and again, you kind of lump this into the same, kind of similar side effect profile as something like the benzodiazepines, which we'll talk about, so like Xanax, right? Because again, they're working on GABA as well, but they all kind of present very similar, very sedate, ataxic, in some cases respiratory depression at very high doses. And so I always talked about Oxysomanex. My patients would come in the ER. Oxysomanex is a combination of oxycodone, carisoprodol, which I did not put on this list, but it's another skeletal muscle relaxant called Soma is the brand name, and then Xanax. And this is commonly co-prescribed together. Patients would take them all at the same time, either to abuse it to get high, or inadvertently because they were trying to manage their own pain, or they're trying to harm themselves. They come in there very, very sedate, and it's very difficult to manage because, again, you can't reverse two of those medications. I can fix the oxycodone, I can't fix the other two. So again, it's tough because then they end up intubated, they end up in the ICU, and they get a secondary pneumonia because they're intubated. It gets bad, right? So again, be very careful when you're co-prescribing these medications. Review their med profile because they're probably not just seeing you, they're probably seeing someone else as well where they're getting some other meds. Okay, things to think about. Capsaicin. Where do you find capsaicin? Oh, yeah, go ahead.
Are muscle relaxants on e-force? Are they considered?
They're not. In a lot of cases, they're not. So the one exception to that, I would say, is carisoprodol or Soma. That is the state of Florida made that a C4. In a lot of states, and federally, it's not a controlled substance. So again, that's sometimes you can find the state by state. You may find a little bit of difference there. So yeah, those you would not be able to see. I can see the Xanax, I can see the oxycodone, but that would not tell me that. However, if I see that, imagine you have a patient who comes in, we got this all the time, patients with overdose on some unknown medications, right? That would come in, we had no idea what was going on, and this is before E-Force. We wanted to figure out what their med list was. Well, what would we do? Call pharmacy. Well, how do I know which pharmacy they fill that? Your drug screens oftentimes come back negative. It won't show up on a lot of stuff. Well, guess what? Where do people probably fill their medications at? Probably Walgreens, or probably a CVS, or probably a Walmart, right? So again, one of those three probably got some medications there. So I can just call them up and say, hey, I have this patient in the healthcare facility. I'm a pharmacist working here, I'm a doctor, I'm a PA working here. Can you please help me out with their medication profile? You provide identification, and then they will give you that information, right? Because again, healthcare provider, that's necessary information. We can figure out all the medications they might be on.
What about combination of the muscle relaxants with anti-migraine?
Mm-hmm.
Prescriptions wouldn't have the same effect as with opioids?
Depends on the migraine medication. We'll talk about those more. Yeah, so like Fioricet, Fiorinol, those are common ones we see a lot of patients inadvertently overdose on. Fioricet's a barbiturate, and we'll talk about those in the neurology section, but those are very sedating as well. Yeah, for sure. Okay. Anyway, so capsaicin comes from chili peppers, right? And whenever cut up a pepper and you, for whatever reason, you always want to touch your eye right afterwards. Always get an itchy eye, always want to touch it, right? It's terrible. The same thing applies here, right? So again, this can really irritate mucous membranes. Very good for treating pain because basically what it does is it depletes substance P from the neuron endings, right? So you'd apply this to wherever the pain is actually occurring. So this is not good for very diffuse pain, for systemic pain. This is better for kind of localized areas of pain, right? So if you had a certain area of, say, postherpetic neuralgia, if you had a certain area where there's a certain injury, or maybe it's, osteoarthritis or something like that, this is a really good medication for those kind of local areas, okay? The thing is, though, is that if you imagine you put peppers on your skin or, say, mucous membrane, what does it do? It burns and it hurts, right? Same thing happens here, right? So again, it's going to be uncomfortable, but once you deplete that substance P, which is really important for propagating pain, you're going to find that it will get better. It will dissipate over time. However, if I stop using it, it's going to come right back. So the problem is this one is compliance. You need to make sure they're using it consistently. It works very effectively if you use it every single day as you're prescribed. And some of this is available over the counter as well. You need to use it effectively, right? And you need to use it consistently. Otherwise, the pain's going to come right back once that substance P starts to build back up, essentially, right? So very good for that. Again, have to make sure they're always either wearing gloves when they're applying it or make sure they're definitely washing their hands. Is just water going to be good enough for that? No, it's a lipophilic substance. You need to use soap and water, right? That soap is going to be able to get rid of that oils there, right? You know, and those are calls we would get from into poison centers and stuff. We did have people who had, you know, got exposure to, like, you know, habanero or something like that, and they had gotten into their mucous membranes and want to know what to do, or they had pepper spray, which is based off a lot of the same substances as well. I had one kid who accidentally let off, it was called bear repellent, which is just pepper spray essentially, inside of a car when they were going on vacation. So I had 5 people exposed at that point. It's tough, right? So again, one of the things you'll find is that lipophilic substances are really good for helping to get rid of that burn. So for instance, I had one lady who had, you know, her whole skin was just starting to turn purple because it was so inflamed from some of these pepper exposures. We used olive oil. That's what she had in the house. Olive oil is very good because it's lipophilic. It'll help to get those lipophilic spicy substances off of the skin and into that. You can use whole fat milk. You know, anything like that that's very fatty is very good for that, right? So either soap or water or a lipophilic substance. Not your skim milk, not your water. That's also a handy tip if you go to the, I don't know, get your spicy curry or get your spicy Mexican food or something like that. Milk is the thing to go with, right? Because it's fatty, right? Full fat milk.
But Dawn, like any kind of dishwashing soap is good?
Yeah, any kind of soap, because again, it's a surfactant, right? So it's going to be able to dissipate that oil there, for sure. And we know what the scale you use for measuring spiciness? Scovilles, yeah. So it's named after a guy, something Scoville, and so that's how you measure the spiciness of a pepper. There's a really funny, there's a good YouTube series called Hot Ones where they have like celebrities come on and they get like progressively hotter and hotter hot wings. And they'll give you the Scoville scale of the different hot sauces, and so eventually they start hallucinating and it gets very, very weird towards the end. Peppers do weird stuff to you. Anyway. I digress. Now, Tramadol, I probably could have lumped in with the opioids, but this one's a little bit different here. It's a very synthetic sort of medication. It's a partial agonist at the opioid receptors. So again, you get some opioid effect from it, but it's pretty weak compared to some of the other ones. Probably a little bit stronger than codeine, but definitely less strong than something like a hydrocodone or say morphine or something like that. Also, the nice thing about it being used for neuropathic pain is it inhibits the reuptake of serotonin and norepinephrine. And we'll talk about reuptake inhibitors later when we get into the behavioral section, but this is very useful for that neuropathic pain. So anything that's blocking reuptake of norepinephrine is useful for neuropathic pain. This is one of those medications there. Now, it used to be a non-controlled substance, which was good for especially like nurse practitioners and PAs before you could prescribe controlled substances here in Florida. You could be able to prescribe this. It was nice because it was a little bit stronger than, you know, an NSAID. It was better than Tylenol, but it wasn't a controlled substance. But enough people were abusing this. Even though it's not a very strong drug, they're still abusing it because where there's a will, there's a way. And so it actually became a C4 medication, right? So because of that, it is now a controlled substance. Now you have to have more scrutiny on that. You'd have to have a DEA license to be able to prescribe it, et cetera, right? So that's one of the big differences you see there.
So does this last, or do they still have to have a paper prescription?
No, so with anything that is 3 through 5, you do not have to have on paper. Usually it will become on paper. For the most part, it needs to be on counterfeit evident paper, right, or tamper-proof, tamper-evident paper, or it could be called in, it could be faxed in, something like that. Anyway, you may see also combined with acetaminophen in a combination called Ultraset. What's the problem when you combine acetaminophen with these drugs? They're taking the acetaminophen outside of it as well, right? They're taking over-the-counter acetaminophen. You can get above that 4-gram limit pretty easily there, right? So you have to be careful with that. And then there's medical marijuana. Medical marijuana has been available in Florida since 2016. And again, you're going to find this becoming nationwide. It'll become much more available, especially as more places are allowing it recreationally, et cetera. And so the law, when it came into place, it said basically that it could be used for the following debilitating medical conditions. You notice here things like cancer, epilepsy, glaucoma, PTSD, which you guys can all classify for that after you're done with my class. Parkinson's disease, MS, and then any other debilitating medical conditions, blah, 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 that you think could work. So basically kind of give you carte blanche to say, like, well, if you think medical marijuana could work, go for it, try it, see what you think, right? You still have to have special registration in order to prescribe this, because federally it's still Schedule I substance, right? So again, it's just that the states have now allowed for it to work, and the government's just not coming in and cracking down on it, essentially. Okay, that's kind of the big difference with that. Now, why does THC work for pain? You know why? I don't really know why either, right? So there's a couple different components for medical marijuana. So, and again, there's nothing different between the medical marijuana versus the marijuana you might buy from someone off the street or from a dispensary. But the main plant they get this from is the cannabis sativa. That's the main common one you're going to run into. There's a few other varieties as well. And there's a few different components. The main psychoactive component, anyone know what that is? THC, right? So delta-9 tetrahydrocannabinol, or THC, is the main psychoactive component, right? It's going to have a little bit different effects than cannabidiol, or CBD, and CBD is actually getting a lot of popularity. That is available. You can get it from any smoke shop you go to. I mean, you can get it from anywhere, right? So CBD is now available pretty widely, and so that actually has a little bit different profile. It doesn't have as much of the kind of euphoric sort of effects there as well, but the nice thing about it is that it had really good effects for really treatment-resistant seizures, and so we can talk about that a little bit there. But anyone ever heard of Charlotte's Web? That was a strain of, not the book, but there was a strain of marijuana that had almost virtually. You seem very excited about that. Some pig, yeah, but actually it was very low in THC, almost no THC, but had high cannabidiol concentrations, and so it actually was very good for patients with like Lennox-Gastaut, epilepsy disorder. Like it was good for some of those, and so but now, since it's become a little bit more widely available due to the medical marijuana bill that passed there in 2016, now patients have better access to it. Now, the main way it's working is working on the CB1, and there's also some CB2 receptors, but the main one we care about is CB1. And typically what you're going to find is that THC is going to be better for more like general like kind of pain conditions. The cannabidiol is better for more the neurological sort of things. So if you think about the seizure disorders, you think about like the anxiety disorders, things like that, cannabidiol tends to be a little bit better for that. THC is better for some of the other things. And so what kind of side effects do you think you'd expect to see from marijuana?
Slow perception of time.
Okay, yes, maybe slow your perception of time, general slowing of the person's mental status, right? Yeah, slowed reaction time. Why could that be a problem?
Driving.
If you get out into a car, right? So again, you have to let patients know, like, you're going to be impaired when you're taking this stuff. Some people do develop some tolerance to that, but you have to be really careful because you're driving while impaired, just like if you were drinking alcohol, right? What else? Yeah, there's some paranoia. So some people do not respond very well to these. You have to be really careful with that. Some people have some paranoid effects from that. What else?
Increased appetite.
Increased appetite, right? You get the munchies. We'll talk about respiratory in a second. But you get the munchies, right? Who would that be good for? Cancer patients. Who else? More progressive, like HIV patients, anyone who's having muscle wasting or any issues with that, medications that could be causing anorexia, things like that, like that's really good for them. And so medical marijuana is very handy from that standpoint. See what else? What are some other things? What'd you say? Yeah, so you get some short-term memory impairment seen with that as well. Can you get addicted to marijuana? Oh, psychologically. It's different than, is that different than physically? Yeah, so again, you do develop some degree of physical dependence. It's pretty light, though, compared to things like opioids, for sure. But certainly there could be a psychological component to it. Could be more of a social component to it as well. If your patients are around it all the time, maybe that could be kind of have an effect there. But generally, considered very safe, generally as long as they're not getting behind the wheel of a car, generally not a whole lot of addiction or withdrawal seen with that for the most part. So again, that's why it's kind of being a preferred agent for some of these things because of the, and again, it's natural, man, right? So again, some people don't want to take medications. They're better off, they think they're better off taking something that seems more natural, even though cyanide is a natural substance, right, in apple seeds. But, I digress. So just know that it's complex. We don't know fully why it works for everything. And is it gold standard first line for any really disease state? Not really, right? And again, we've talked about some cannabinoids before in the GI section, right? We have Marinol, we have Dronabinol, right? That is acts on the same receptor. So again, this is good for if they've tried other stuff and nothing's really working, they can try this. That's fine, right? If they have, they really don't want to take the other stuff, they can try this. That's fine, right? It's at least worth a trial. At least it's available for patients who may actually benefit from it, right? Now, getting into the dosage forms, how do you get this into your system? You can ingest it, right? So there's a PO route. What else? Smoking is the other big one, right? So again, Yep, so it can be by the oral route, right? So there's lots of ways you can incorporate it there. What do you think the kinetics are of it, say the inhaled route versus the oral route?
Faster.
Which one's faster? Inhale's much faster, because again, it's getting right to the lungs, right into the circulatory system, versus having to go through GI tract, get dissolved, get absorbed, go through the liver, his first pass, all of that, right? So you think about the kinetics of it, right? So again, one of the problems we saw in a lot of places where they allowed for recreational use is that people would go, they would get a lot of edibles, right? They would take an edible, and they, 30 minutes later, they wouldn't feel anything. They're like, so they take more, right? So they say, well, let me go take some more. So they take another dose. 30 minutes later, they don't feel anything yet. What do they do? They take another dose, right? So again, the thing is they'd understand the kinetics that it took like 90 minutes for some of the stuff absorbing it to the system. And so when they got high, they got way too high. And so that would ultimately lead people to go to the ER, right? How many people do you think you see in the ER for marijuana exposure? 0, right? Some of these people are actually coming in because they were so severely intoxicated from this that they were just freaking out, or they're having this paranoia, whatever. They needed to go to the ER. They felt they needed to go. But again, very safe and overdose for the most part. So be careful with the kinetics there. Let them know it takes time for it to absorb and to kick in, okay? People will figure this out when they start to take it on their own. They'll kind of get a feel for what works for them. Now, what's the problem with the inhaled route? Yeah, so it depends on how they're inhaling it, right? So again, if they're actually like lighting up a joint or something like that and inhaling it, that hot gas and all those, there's still carcinogens and there's still natural products you're inhaling that are dangerous, right? And again, the hot gas is very damaging to the epithelium of the respiratory tract. So you can still see some damage there. That is mitigated somewhat by something like by vaping and things like that, where the gas is not quite as hot. You get a little bit more of a pure substance. So there's things to consider there. But who might be a bad candidate for the respiratory route? Yeah, COPD patients who have reactive airway disease, things like that, right? So again, while it's a very safe drug, think about the other components that are in the product. Think about the disease states that may be interacting with the route that you're going for. Think about things like that, okay? All right, so anyway, as I mentioned, we talked about the side effects. Chronically, we don't really know what the full chronic effects are going to be, because again, how easy was it to do studies with a C1 substance? Near impossible, right? And again, it's kind of interesting when you look at it. When you could do a study with marijuana, there was like one lab at a university where they were growing it, and apparently it wasn't even like very good strain. So like the amount of THC they actually had was not very good. But now that's becoming more available. Hopefully, at some point we'll be able to get better studies done, and we'll figure out these chronic effects here, right? There is some concern about impaired memory, lowered IQ potentially, but overall it's very safe from the acute standpoint and the chronic standpoint. Just you're going to be impaired. Don't get behind the wheel of a car, right? Okay, so again, pain management is very complex. It needs to be individualized for every single patient, because pain is ultimately objective or subjective? Subjective, right? But also look for the objective findings, right? Can your patient get around and walk around the unit before they couldn't, right? Can the patient turn over in bed? Can they go back to work? There are functional objective things you can look at to see, is your pain management working? And typically, like we said, patients who are on effective pain management, they gain function, right? Not every patient you put on pain management is going to gain that function, but that's what you're shooting for, right? Some people lose function, it's usually the addiction and things like that kick in, but that's what you're shooting for, okay? Any questions on that? All right. So let's see, getting into, let's do a 5-minute break. We'll come back and then do the rest of this.
Does it kill your brain cells?
Does it kill your brain cells?
Yeah.
I don't think it has a direct effect to kill your brain cells. I would not say so. Unless you became anoxic, right? Maybe you were inhaling way too much smoke and you had no oxygen, perhaps.
Do you know how they get the plants to make Delta 9 THC?
How they get the plants to make it? It's from the actual seeds, right? Any questions from the first half? Very enlightening conversations on marijuana. I must say, my experience is zilch in that realm. I was a very nerdy child growing up. Had no access or exposure to a lot of that stuff until I got into medicine. I saw these people coming into the ER, and so maybe I'm only seeing the worst side of it, but it's very interesting regardless. So I always like to watch documentaries, like on Netflix. Like, sometimes you, again, take everything with a grain of salt, but like really interesting things like dimethyltryptamine, which is DMT. Looking at documentaries about that, like that's really interesting. Ketamine's really interesting. So there's lots of cool stuff that's out there that, unfortunately we can't do a lot of good studies on and things like that. But anyway, so getting into the room talk, let's talk about the immunologic response. And have you started talking about any autoimmune conditions yet? About rheumatoid arthritis, you've kind of covered, right? So, and essentially, what's the issue with rheumatoid arthritis? What's the problem? Inflammation, autoimmune inflammation. All right, so again, we're attacking ourselves, right? And again, you're going to find the pathophysiology is pretty similar amongst most of these different disease states, right? So whether it's lupus nephritis, whether it's ulcerative colitis, you're going to see a lot of crossover of a lot of these drugs because again, they're shooting for similar targets in the inflammatory cascade, right? So again, in GI, we talked about ulcerative colitis, we talked about Crohn's disease. You're gonna see some of the drugs come up again because they're shooting at the same targets here, right? So again, the idea is to decrease inflammation and decrease the body's desire to attack ourselves, essentially, right? So again, I'm not going to get super deep into the details here because we've covered this before. We know about the inflammatory cascade. We know what kind of enzymes are we going to be targeting here. Well, like what's a big inflammatory enzyme? Prostaglandins that are produced by cyclooxygenase, right? So we've talked about that before. We know about cyclooxygenase and how it works in inflammation, right? We've talked about things like tumor necrosis factor and how that helps to stimulate the immune system and draw more, leukocytes to the area of inflammation, right? We know about these different things, interleukins, different things like that. So we're going to talk about these more, and so you can review that stuff. But again, we're trying to decrease inflammation by decreasing the different steps in the pathway, right? And again, we've talked about powerful anti-inflammatories already. What's another group of anti-inflammatories we've talked about? The non-steroidals is even more powerful than that. Corticosteroids, right? Our corticosteroids are very powerful anti-inflammatories because where do they work? They work in the nucleus, right? They decrease production of inflammatory cytokines from the top of the pyramid all the way down. Very powerful anti-inflammatories. However, we know there's a lot of side effects. So again, we're going to review some of this stuff, but again, we know a lot about a lot of these already, which is great. And again, remember that cyclooxygenase pathway is very, very important. So our NSAIDs are going to be working to produce things like prostacyclins, prostaglandins, thromboxans, etc. And that's going to be one of the big targets there. And notice here, this is where the steroids are going to be working at to decrease, kind of stop that from even a step further up the chain than the NSAIDs are. So anyway, so again, I'm not going to get specific on the epidemiology all of here, but again, how does rheumatoid arthritis normally present? Painful joints, usually bilateral, right? Which can be different. Then we'll kind of talk about osteoarthritis kind of in parallel with this and see how the pathophys is different, to see how the treatment is also different between the two, right? Because again, you're going to run into patients who may have one or both, or as we'll see, and so the treatment's going to be very different between the two there. But basically, what you're seeing is that joint destruction of the synovial lining, right? So again, the immune cells are getting activated, they're inflamed, it's attacking those joints, and that's where you see a lot of deformation that happens there, right? And we've never seen like in patients like really progressive rheumatoid arthritis how deformed their hands can get. What happens with those hands? Like, are they functional anymore? No, they have a hard time performing any activities of daily living. One of the things you're going to find is that one of the products we use are injectable products, right? You have like injectable pins they can use as part of that. But if your hands are so bad off that they can't even coordinate that, it's going to be problematic, right? These are things that you have to start to think about as far as what the functionality of the patient is, what kind of access to support they have, etc., right? That is choosing what the best treatment is for them. Again, I kind of want to get to the actual picture here and give you an idea what that looks like. Again, remember things like interleukins, tumor necrosis factor, very important pro-inflammatory cytokines. This is where some of our medications are going to be focused on, right? And again, what type of drugs focused on just very specific inflammatory mediators? The biologics, right? The monoclonal antibodies that we had that specifically targeted those, right? Think about those. We're going to talk about those a little bit more in just a few minutes here. So again, here's what you see in sort of a normal sort of joint here. But again, as the immune system starts to get really over amplified, this is where you're going to start to see destruction of those joints there. And again, the joints will appear different than between osteoarthritis versus rheumatoid arthritis. How might the joint look different, say on your physical exam?
Like the joint VIP versus VIP.
So not necessarily which joints are involved, but how do the joints themselves actually appear different? Very inflamed, they're hot, they're red, they're swollen, versus osteoarthritis may not see that. Osteoarthritis we're going to find is more of just a mechanical sort of issue there, right? So again, the pathophys is very different, the joints look different, the treatment is going to be different, as we're going to see there, right? Because again, with something like osteoarthritis, what's the ultimate treatment for that? Give them a brand new joint, right? I can just take them out and make them part metal, right? Make them part robot, make them better than they were before, like the $1 Million Man. This on the other case, if I took out the joint and put a new one in, I'd still be in the same problem I was before, right? Metal might not be affected, but you're going to find that joint, that inflammation is still there. So again, oftentimes this tends to be lifelong sort of therapy, these patients. just like we saw with ulcerative colitis, Crohn's disease, etc. Right? So OA, though, we know this is very, very common, much more common than RA, but it affects a ton of patients. What type of patients get affected? Older, you kind of worn out their joints. Who else? Athletes potentially, like, from overuse. What else? More often than athletes, obesity, right? That's a big thing, right? Because again, they're putting all that extra stress on those joints, wearing and tearing over that long period of time, right? It's the biggest thing you're going to see, right? Much more likely to see the overweight individual than you are to see the athlete coming in for OA, right? And typically tends to be a little bit more, could be unilateral depending on kind of what's going on there. But if you look at a normal joint versus osteoarthritis, you can see here again that synovial line is kind of being worn down, the bone's starting to rub on bone, which is why you get a lot of that pain associated with that. However, when looking at rheumatoid arthritis, you can see here it's just red, hot, inflamed. Inflammation is much more prominent there than it is in osteoarthritis. Okay. So anyway, looking at this, you can see again that damage to the articular cartilage, that leads to either due to stress over time or due to that specific injuries there. And again, you're going to have this apoptosis of the chondrocytes. Those are really important for producing that synovial lining over time. When you lose those, you're going to not be able to really produce that lining any further. Okay. And again, you're getting that mechanical damage. There is some degree of inflammation, but not nearly as pronounced as RA. So that's one of the big differences there. And then that pain is due to those nociceptive fibers, right? Those pain fibers being sensitized by that actual mechanical and chemical irritant sort of triggering them off. And so we're going to find that, for instance, with the pain associated with RA, opioids really don't have a place there. However, opioids might have a place for osteoarthritis because, again, the pain is going to be more centrally mediated because you're activating those nociceptive fibers versus it purely just being inflammatory, right? Kind of make a sense? A little bit of a sense? Okay, so again, you kind of look at the differences here and how the joints are actually presenting. Okay, so our goals here for both RA and OA is going to be to try to relieve pain stiffness. We're going to try to reduce inflammation. If it's present in OA, then you can shoot for that, but definitely for RA, that's going to be one of the main goals. And then we want to try to definitely improve their function and the quality of life, right? So make sure they can get up, get around, do their thing. And in a lot of cases, we're trying to slow down joint progression, right? So again, what's the biggest thing that someone with OA can do to try to slow down that joint destruction? Lose weight, right? Reduce the amount of stress you're putting on the joint. That's going to be the biggest thing you do, right? So exercise, PT, OT, all that's going to be very helpful for them to help get rid of that or to slow it down, essentially. And for RA, how do you think we're going to slow down that joint destruction? Those are going to get in our biologic DMARDs, right? We're talking about our drug. I'll talk about the acronym in just a minute, but it's basically disease-modifying anti-rheumatic drugs, right? We're going to talk about those. Very similar to what we saw with ulcerative colitis and Crohn's, we're going to have drugs that help to slow down the progression by decreasing that inflammation over the long run. So when I say DMARDs, we'll talk about what those are in a few minutes. And so again, obviously there's a lot of non-pharm therapy that goes into this. We'll see that, obviously for OA, surgery is going to kind of be the end stage there. It's going to be the ultimate definitive therapy. Don't really have that in rheumatoid arthritis so much. But again, let's focus on the pharm because that's what we're here for, right? So anyway, so here's the differences, and we'll get into the specific medications on how you're going to be managing these. But with RA, you're going to find that the chronic treatment, again, just like what you see in Crohn's, they'll go through periods where they'll have kind of long-term maintenance therapy, but they'll have exacerbations, right? They'll have flare-ups. We'll talk about how to manage those. But normally for chronic treatment for RA, it's NSAIDs, maybe low-dose corticosteroids. This is one of those cases where you might find someone who's on prednisone chronically. Again, there's going to be side effects associated with that, but that's what you may see. Obviously, what's our goal with corticosteroids? Get them off of it, right, if you can. You don't like corticosteroids on chronically. For acute exacerbations, this is where we're going to be using corticosteroids for sure to try to decrease that acute inflammation. There our DMARDs are going to come into place. And in some cases, especially for things like knee effusions, you can do things like aspiration, and you can actually inject corticosteroids actually into the joint. I remember one time I was in the ER, we had a patient with juvenile rheumatoid arthritis who had come in. Knee was just huge. Like it was basically 2 or 3 times the size of his other knee. It was unaffected. And so the rheumatologist was going to come down because it was right before the weekend. The kid wasn't going to be able to get in to see into the clinic. And so the rheumatologist came down, and we were going to aspirate the joint and then inject in a corticosteroid there. And so I was in the room with him because I had the corticosteroid because again with any kind of joint injections, that has to be sterile, right? You want to make sure you're doing under sterile field because if you get an infection in there, it's no good. So anyway, so the doc went in and he was actually pulling out fluid from this kid's knee. And I've never seen so much fluid come off such a small space, you would think. I mean, I think probably 200 mLs of just fluid coming out of this kid's knee. And immediately, how do you think the kid felt? Way better, right? All that pressure was off of that joint. He felt tons better. And then we injected the corticosteroid right afterwards. But it's just like crazy, like how much inflammation, how much of that exudative fluid is just going to be kind of building up there. You can see why it gets so painful, right? Just all the pressure there on the joints. Anyway, for OA, you're going to find that things like Tylenol is going to be very important for chronic therapy. NSAIDs can be useful, and then also if you're dealing with more localized areas, if maybe only a few joints are being affected, topical therapy is going to be very useful. So what's the benefit of topical therapy? Limit systemic side effects. Absolutely fantastic. For acute exacerbations, opioids can be used. Now, a lot of patients with OA, they tend to end up on opioids chronically. That's a problem because, again, we know there's lots of side effects associated with that. They know the physical dependence. Not great. So if we can keep people off of chronic opioids, it's always going to be better. And then, again, you can also do things like aspiration potentially, but corticosteroid injections are pretty common as well for those patients. So looking at RA, so the DMARDs are going to be the disease-modifying anti-rheumatic drugs. Those are going to be like our monoclonal antibodies and things like that. They're going to be playing a role into there. They can fall into the biologic or non-biologic category. When I say biologic, what does that just mean? It's a protein, right? So it's usually the monoclonal antibodies we're going to be looking at. We also have non-biologic ones. Some of these are going to look very similar to UC and Crohn's like we talked about previously. So we'll talk about those in a second. These need to be started as early as possible. Why is that? You can save as much of the joint as possible, right? So again, you want to start early as best you can, so that way you save as much joint as possible. More favorable outcomes when you see that. And then the NSAIDs and the corticosteroids are going to be better for the sort of symptomatic relief. They're not going to be good for helping to slow down the progression. They're just going to be there to work on the symptomatic aspects of it. So our traditional DMARDs for rheum are going to include methotrexate. We've already talked about extensively, so you know a lot about methotrexate already. We have another one called hydroxychloroquine. We have sulfasalazineoquine. Have we seen that before? Yep, back in GI we saw that one. And then leflunomide is another one we saw there. Okay. So, and then for the biologics, we have our anti-TNF. So we have things like infliximab or etanercept, adalimumab, golimumab. Probably the two most common ones we use for our kids with like JRA are going to be infliximab and adalimumab. Now again, which one you decide to use can be dependent on how the drug has to be administered, how often it has to be given. The nice thing about Humira, it comes as a nice injectable pen. They can go home and inject themselves versus having to come to the infusion center to get infliximab, right? Again, these are little things we'll talk about, but some of that is going to dictate, which drug you're going to choose for your patient. Now, if they fail one, we'll talk about how you switch and things like that, but a lot of that can play a role there. And then there's one co-stimulation modulator we might talk about a little bit called abatacept. And then there's also some interleukin antagonists, things like tocilizumab, rituximab. And then this is part of the newest one. This is actually kind of the most novel out of the bunch. This is actually a tyrosine kinase inhibitor. It's called tofacitinib, or Xeljanz, and this is actually has the newest novel mechanism. We'll look at how that works. The nice thing about this one is actually an oral product. So it's an oral DMARD that has been very effective. I'm starting to see more patients being actually put on this. And again, my perspective is really only from the pediatric side, so I don't deal with a lot of rheumatoid arthritis for adult patients. So you may see some differences there, but the same drugs are being used essentially, right? Other agents you may see, azathioprine, D-penicillamine. We're not going to talk about these specifically, but even gold used to be used. So those are only the richest patients who got the gold there, right? No. How do you think it works? Well, metal, it's a heavy metal, right? Heavy metals tend to be toxic to cells, just like lead is toxic to cells. You can find that gold actually has some anti-inflammatory sort of activity there. So you used to use gold products. A lot of toxicity is seen with it, so you don't use it anymore. Does anyone know what the term, or has heard the term, born with a silver spoon in your mouth? Mm-hmm. What does that mean? Nowadays, it means you're rich. But what it used to mean is that you were healthy, because silver antibacterial has an antibacterial property. We still use silver sulfasalazine. So we use some silver-containing products. It used to mean if you were healthy, this is back in the day, you had a silver spoon born in your mouth because it was antibacterial. This is back in like the colonial days, back when, if you got infection, you stub your toe, you're going to die from sepsis or something, right? So, again, nowadays it's kind of morphed a little bit. But yeah, so heavy metals can be used because they have some anti-inflammatory, some antibacterial sort of properties. And then we see cyclophosphamide. Where do we see that before? For chemo, right? So again, just like it's good for treating leukemias, where you need to tamp down the immune system because those cells are cancerous, here you can use the same thing. How do you think the dose would change between the two? Usually lesser for these, right? So the methotrexate dose you see for rheumatoid arthritis, much lower, much longer therapy than you would see for cancer, right? So you'll see some differences there between the dosing strategies, how much they're getting, how long they're getting for, etc. So generally, we don't know why the full mechanism of how they're working. We'll talk about that. We know what the actual mechanism is, but again, overall, why they're slowing down the progression, we don't necessarily know. And what you're going to find is that for most patients, they'll probably start off on methotrexate. That and hydroxychloroquine have the best efficacy to toxicity ratios for the most part, and they're tried and true. They've been used for decades now. And they find that if you're using methotrexate and corticosteroids, even as far as 5 years out, over 50% of those patients are still using those therapies. You're going to find that, it's going to be progression, right? So, because you can't slow down the joint progression entirely, so you need to kind of step up your therapy as you go on, but that's a very good combination of methotrexate and corticosteroids. And in some cases, you may need to use multiple DMARDs. And again, when you're combining DMARDs, what do you think you're going to be thinking about? Higher toxicity for sure. What else do you want to think about? How about from efficacy standpoint? Different mechanisms, right? You want to use things that are going to be complementary to one another, as we'll see. So as I mentioned, methotrexate probably going to be first line for most RA patients you're going to see out there because you have the best long-term data there. And it's usually a good component, it's a good backbone for a multi-drug regimen, as we'll see in a few minutes. We'll talk about combining drugs in a second. So what you're going to find is that typically the traditional DMARDs, like your methotrexate or hydroxychloroquine, they take time to kick in, so 3 to 6 months or so before you see full efficacy. So because of that, you want to start off very early if you can. The earlier you get the diagnosis, the better. And then you're going to be kind of supplementing that in the in the short term by NSAIDs, corticosteroids, et cetera, to help with that. Some of them might work a little bit faster, like methotrexate, kick in about a month or two, which is a little bit nicer from that standpoint, which is why we like it. Biologic DMARDs, because they're very quick to act directly on the already produced inflammatory cytokines like interleukin or tumor necrosis factor, they work within a couple of weeks. So much faster onset, which can be good for those kind of acute flare-ups for some patients there. And we'll see that therapy results in immunosuppression, just like we saw with these monoclonal antibodies before. And so you need to consider doing a TB test before you start any DMARD listed here, okay? Because again, what happens if you have TB and you get started? Yeah, you could reactivate a latent infection, so you want to be careful with that. How about vaccinations? You want to avoid live virus vaccines. Why is that?
Because it can actually do something to you if you have a suppressant.
Yeah, so if you're on immunosuppressant and you take a live vaccine, it's attenuated. It's a weakened form of the virus of the bacteria, but it could actually cause disease in those patients. Also, with a suppressed immune system, can you really mount up a good response to become immune to that vaccine? You can't really. So oftentimes we'll recommend either doing it, say, get a live vaccine or inactivated vaccine, say 2 weeks beforehand, or maybe even 3 months after they stop some of these DMARD therapies there. So again, to take that into consideration, right? So again, if they're coming up on flu season, consider whether or not they're going to be able to get that shot or not, so that way they can at least be protected from it. Because you're going to make them immunosuppressed, they're going to be more likely to get infections. So as I mentioned, biologic DMARDs, try to give vaccines beforehand. The killed or recombinant vaccines, they can be given during therapy. So if you think about like the intramuscular flu vaccine is a killed virus, they may not be able to get as good of a response to it, but it's not going to cause disease in them because the virus of the bacteria is dead. So you don't have to worry about that necessarily, but they may not get a good immunization against it. Live vaccines, though, should not be given because it could actually cause disease, as we said. In some cases, you actually will change the recommendations on when to get certain vaccines. So for instance, we'd recommend they get herpes zoster earlier, 50, say, instead of 60, because we know they're going to be increased risk. Yes, ma'am.
Isn't the Shingrix approved for people who are immunosuppressed?
The which one?
The Shingrix.
I believe so.
Yeah, so I know that for Zoster, they couldn't get it, but I think Shingrix you can.
I have to look it up. I don't know.
I had to go to the dinner about it.
Yeah? There you go. So you know more about the topic than I do. You want to give the talk? Yeah, no, I have no idea. I'd have to look it up. Yeah, I mean, because again, if I dealt with these patients every day, I'd probably know it right off the top of my head, but I don't, so I'd look it up. Because again, what's one thing I want you to know if you get out of my class and forget everything else? Look stuff up. Look it up. If you're not sure, look it up. I had a couple students in my office the other day, and I said, well, how does that drug work? And they were like, whip out their phone. For me, I don't mind if you whip out your phone, right? Because you're looking it up. I know what you're doing, right? You're not just checking your Instagram or something, right? You guys still use Instagram, right? That's still a thing? Yeah, okay. Your TikTok, maybe. But look stuff up, right? Now, again, if you're on rotations and your preceptor's pimping you and they're like, hey, what's this? How's this drug work? And you're like, let me find that. Like, that's going to go over bad, right? I'm just going to tell you right now. The older the preceptor, the worse that's going to go over. I can guarantee you right now. However, you're like, oh, let me go look that up and I'll get back to you. That's a very good answer, right? That way you can go look it up, get a good answer, come back to them and be like, hey, here's what you were asking earlier, right? Always follow up with your preceptors. They ask you a question, you say, I'm going to look that up and get back to you. Always get back to them, right? That shows that you actually care, you're actually invested, you're engaged. do that. It'll really make you stand out compared to some other people who might not do that, right?
They don't make fun of you if you don't know right then and there.
I mean, some people might, but there's also, I mean, there's a lot of mean people out there, right? But no, they should not, right? It's okay. You're students. You're not expected to know everything. They might give you a little ribbing. They might give you, oh, you don't know that, huh? Like, they might be a little snarky, but that's okay. You're not expected to know everything. You're there to learn, right?
So the live vaccines, are they okay with the DMARDs or?
No, you don't want to give them at the same time as they're receiving DMARD. This is more specific with the biologics because they tend to be much more kind of potent as a immunosuppressant. I would say use with caution, right? But certainly for the biologic DMARDs, I would recommend not giving it at the same time. If you start beforehand, that's always going to be better because you have a more competent immune system to actually develop that immunity in the first place, for sure, right? Okay, anyway, so you guys keep getting me on tangents. It's not good because I have so much material to cover. Anyway, I'm trying to give you life lessons, or rotation lessons. Anyway, so methotrexate, how does this work? Folic acid antagonist, right? So again, we can't produce new DNA because we can't produce things like thymidine to make into the incorporate into the DNA. So you're stopping those immune cells from reproducing. Okay, easy as it gets, right? How would I treat methotrexate toxicity? Folinic acid, right? Or leucovorin, not folic acid. Folic acid ain't gonna work because it's inhibited by methotrexate. It's like a folinic acid, right? These are things to consider, right? I've gotten several calls to the poison center where a lady was, or people have, been treated for rheumatoid arthritis. They inject themselves one time a week, and the lady forgot when she had injected last, and accidentally gave herself a second dose. She didn't remember until right after she gave the dose. She's like, oh darn, I shouldn't have done that. And then they come in. Now we got to check levels. Now we have to think about giving things like sodium bicarb, giving folinic acid, etc., to prevent that toxicity. Right? These things happen. But anyway, so yes, we know exactly how it's working. It's preventing the synthesis of thymidine, cysteine, etc., which we need to produce new DNA and new immune cells. Again, you've seen the picture, so I'm not going to belabor that because we've already covered it. But again, what kind of toxicity do you expect to see from methotrexate? Hepatotoxicity is a big one. What else? Immunosuppression, good, so infection risk is going to go up. What else? Myelosuppression, right, so it kind of goes on with the immune suppression.
Entry to the renal tubules with acidic urine.
Yeah, so, okay, definitely you can see that. When would you expect to see that more? More with, like, cancer treatment or more with, like, normal? Yeah, typically cancer treatment, right, because you see a lot bigger doses you're giving to those patients. But, however, imagine what's the normal age for these rheumatoid arthritis patients you're going to be dealing with? Older, typically. More, like, think like more chronic management. Like, you think older patients, how their kidney function doing, getting worse, and maybe they get a little sick and they don't, their PO intake goes down. All of a sudden they're dehydrated. The renal tubules are going to be more acidic. They're not as kind of plumped up with fluid. Guess what? That methotrexate can precipitate out and cause acute kidney injury. Absolutely, you can see that. How would I treat that?
Sodium bicarb.
Sodium bicarb and just more fluids in general, right? Just more fluids in general is going to help them out. Sodium bicarb helps to alkalize and get that more soluble, right? Anything else I can see? Think about the mucositis, right? Think about things like that can be affecting the reproduction of those GI cells as well, right? Obviously contraindicated in pregnancy, contraindicated for patients with renal insufficiency. Because again, because you have rheumatoid arthritis, does that mean you can't get pregnant? Absolutely, right? Because again, we have JRA, we have juvenile rheumatoid arthritis. We have patients who are going to be of all ages who can be potentially getting some of these medications there. So this is things you have to consider. Like, are they going to be on prophylactic, oral contraceptives, or are they going to have, you can talk about child planning and things like that. Because again, you have to consider what medications they're receiving, going off the medications, what that might mean for them, etc. It can be very complicated, right? Anyway, as I mentioned, most common used DMARD, usually get your mechanism of action kicking in within a month or two to get pretty acceptable effects there. And as I mentioned, lower doses than for cancer. Now, oftentimes you may either see patients either on PO doses or they may use sub-Q IM doses, usually less frequently. They may get like one injectable a week versus, say, taking an oral tablet every single day. Right? So you may see a couple of different forms there. And as I mentioned, monitoring. Look at your CBC, look at your LFTs. These are all things you have to monitor at baseline and then follow up with them to make sure they're not going to be getting too elevated, cause you to have to DC the med and switch over to something else because of that. Okay. And then typically we'll give folic acid along with it. And you would think, well, wait a second, you just said folic acid doesn't reverse the toxicity. This helps to kind of just in general keep the cells kind of supplied with folic acid so that way, maybe those cells are not as rapidly dividing. They don't really need the folic acid to produce the DNA, they can still get some benefit from that folic acid, right? So we just kind of do it not as an antidote, but just in general, try to keep the stocks up in the cells and try to keep things healthy as best we can. Sounds counterintuitive and kind of is a little bit, but it helps to keep things working. Methotrexate is still going to be active, so it's all good. And again, folic acid is cheap. Any side effects seen with it? Nah, just drink like a rock star or something, and you got enough folic acid for right. Next was leflunomide. This is going to be, again, working very similar to methotrexate in regards to it's going to be decreasing the pyrimidine synthesis. So again, it's going to be preventing those cells from replicating there, right? Again, very fast onset within about a month or so, which is great, and pretty equal efficacy to methotrexate. Okay, so very good from that standpoint. Could be used probably interchangeably here. You're going to see a lot of diarrheas associated with this. You can see some hepatotoxicity. So the side effect profile looks pretty similar to methotrexate from that standpoint. One thing to note that is very different from methotrexate is the fact that this undergoes enterohepatic recirculation. What does that mean? It goes out through the biliary tract, gets reabsorbed, and goes back through and through. So what do you think it does to the half-life? It increases it quite drastically. And so what you find is it could take months before you could actually drop down to either no levels, or maybe if you had toxicity and levels are too high for it to drop down to acceptable levels, right? So again, it takes months sometimes in order to get down to those levels down. So who might that be a problem for? So you're having liver toxicity, you can't get rid of it, that could be a problem. Who else? What if you want to get pregnant? You stop therapy, but you still got the drug in your system for months. So what we do sometimes is call it the cholestyramine washout. Cholestyramine, remember where we saw that last? It's a bile acid sequestrant, right? It binds up bile acid. So it can bind up the drug in the GI tract and allow it to just be passed out through the feces instead of being reabsorbed. So sometimes we'll do that washout, try to get levels down to negligible levels, and then they can try to get pregnant at that point, right? So again, make sure you're monitoring for pregnancy, LFT, CBCs, etc., right? Next we have hydroxychloroquine. This is going to be kind of the wimpiest out of the bunch here, but it's also going to be the least side effect ridden that you're going to see. So again, it's better for more mild disease or if in combination with something else. It's a good sort of add-on sort of drug there. And basically what it's doing is trying to inhibit neutrophil locomotion. Chemotaxis is going to be inhibited, so you're not going to get as much migration of these inflammatory cells in here. And also is going to be interrupting this kind of complement-dependent antigen-antibody sort of reaction here. So kind of slowing down the process, but you can see how it doesn't necessarily affect the reproduction of these white cells, so it's not going to be quite as potent as something like a methotrexate would be. And response is going to take 2 to 4 months or so, and is not associated with a whole lot of myelosuppression, nor is the hepatotoxicity, the renal insufficiency, so it's good from that standpoint. However, not going to be good for more progressive disease, more moderate, severe sort of disease. Okay, so it's good as an add-on, or good by itself very early on, but it's going to be running out of efficacy, at some point. Other things you may see, a lot of GI side effects associated with it, and you can actually develop a retinopathy. So again, it's good to do visual acuity sort of at baseline, and then follow up to make sure they're still able to, let them know, hey, look for any visual changes. Is their vision's blurred more than usual, or whatever the case may be. And then you can also see some dermatologic reactions. You can see this increased skin pigmentation, kind of a graying of the skin that occurs with chronic therapy. So something else, again, more bothersome from a quality of life standpoint than necessary from a true toxicity, but it is something that could be problematic, right? You'd be kind of mad if someone gave you a drug that changed your skin color, right? Probably. Just like, think about like Latisse or something, and like all of a sudden my irises are brown. I had beautiful baby blues. You didn't tell me about this. You'd be kind of mad too, right? So let them know. These are things to expect. Okay. Next we have sulfasalazine. We've seen this before when talking about ulcerative colitis and Crohn's disease. Again, this one is cleaved by the colonic bacteria, so you get this 5-amino salicylic acid, very similar action to the salicylates like aspirin, and then the sulfapyridine. Don't know the full mechanism, but we do think it has something to do with inhibiting tumor necrosis factor, maybe helping with some free radicals. Anyone know what a free radical is? What is that? It's a reactive oxygen species. What does that mean? It's got a free electron, so it's very reactive. It's going to go through and denature proteins. It's going to go through and damage cell membranes. It's going to go through and cause all kinds of damage. So by being a free radical scavenger, and again, that's what causes a lot of that joint damage to occur, right? And hydrogen peroxide is developed in things like the neutrophils, and that's what causes a lot of that damage. So by scavenging those, you can have to limit some of that damage done over time, right? So again, considered an antioxidant in that way. It's just like you think about like blueberries or ascorbic acid and vitamin C. It's kind of similar. It's a free radical scavenger. And so some patients are going to see definitely significant side effects here, including the nausea, vomiting, diarrhea, but certainly hepatotoxicity, some alopecia associated with this. That you didn't get quite so much of with methotrexate or like leflunomide, but certainly here you can see it. And again, start low, go slow, and see how they're going to respond to it over time. And here you're going to find lots of drug interactions, mostly due to things like either binding up medications in the GI tract, like antibiotics, could be affecting things like protein binding interactions, where it could kick something like warfarin off of the albumin. And what does that cause? Increased bleeding, right? Increased INR, because the more warfarin is active, right? The more drug is not attached to a protein, the more physiologically active it is, right? So those are things to consider. And also, watch out, it's going to turn your stools, urine kind of yellow, orangish sort of color. Because again, if you saw kind of orangish kind of urine coming out, what would you jump to think? Think blood, right? So again, it's one of the things you want to be cognizant of. Orange, I don't think blood, but if you see like a little reddish sort of tinge, like you think blood maybe. So let them know that's a normal change you expect to see there. Now, which patients with UTIs would have orange urine? They're taking azo, nasopyridine, right? So that's something you can see there. I had one patient who had overdosed on azo, and it caused a methemoglobinemia, which anyone know what that turns a patient color? It turns them blue. It looks like a Smurf. So they look cyanotic, but they're breathing fine. They have no distress or anything. They look like a Smurf. And so she had orange urine. Her skin was blue. And then we know what we give them to fix. We give them methylene blue. We give them a blue dye, and it actually helps to convert that back over to normal hemoglobin instead of having met hemoglobin. So we had this blue patient. We give them a blue dye too, and we had her cath at the time. So you see the orange urine coming out, and then now we see the methylene blue, which is dyeing everything blue. So now it turned what color do you think? Orange plus blue is purple. She had purple urine. So if you ever see some purple urine, that could be a possible cause, right? Very interesting to see happen in real time. Anyway, again, these tangents are killing me. Okay, so now getting into tofacitinib, right? So this is kind of the newest medication we have for treatment of rheumatoid arthritis. So tofacitinib or Xeljanz is the tyrosine kinase inhibitor. You guys remember the tyrosine kinase receptors? Right? Remember they're the ones that once they get activated, they dimerize and they get phosphorylated, and then they cause some downstream thing to happen, right? Insulin receptors are tyrosine kinase receptor, right? So basically what this is doing is inhibiting this Janus kinase or JAK protein. By inhibiting this, is basically going to be stopping the activation of these STAT proteins. STAT proteins are useful for causing inflammation to occur. They increase gene transcription for these inflammatory cytokines. So if I inhibit this process, and again, just for my purposes, if you know it's a JAK inhibitor, that's all you really need to know, right? It's a JAK receptor inhibitor. You're stopping the STAT proteins, and that will decrease the amount of inflammatory cytokines that are being produced by changing the actual gene transcription. So think about it, it's kind of similar, almost in activity to something like a corticosteroid. Maybe not as potent, but again, it's getting down to that gene transcription level to affect the inflammation. So it can be very powerful. I'm seeing several patients on this that works very well for. And the nice thing, it's available orally. A lot of the biologic DMARDs we see are not available orally. They would be given via injectable, but this one is, which is very nice. So either used in combination with other DMARDs or by itself, but we do not recommend it for use with other biologics. The reason for that is you can see too pronounced of immunosuppression, you're more likely to see infection. That's no good. And in fact, any two biologic DMARDs you do not want to put together. I have a slide about this, but basically you can use a non-biologic plus a biologic. That's fine. I can use two non-biologics together, but never two biologics together. And so this is another case where we don't want to use Xeljanz along with the biologics. Okay. Again, if someone is on a 3A4 inhibitor, you want to reduce your dose of this because you're going to find it's a substrate for 3A4, but it's not. So the levels are going to climb up if you have an inhibitor on board here. And again, test for TB beforehand because again, you want that to activate. And there's some black box warnings seen with it. So serious infections, you're going to see similar black box warnings to most of the biologic DMARDs for infection for the most part, and then some risk for lymphomas. Okay, so getting into the biologics specifically. Again, these tend to be very expensive. Why? They're proteins, right? We have to produce them in a lab essentially to produce these antibodies, and so they get to be very expensive. The nice thing though, very little monitoring. They don't usually cause hepatotoxicity. They're not going to cause, the actual white cell count to go down. They're going to cause immunosuppression, but the actual white cell count's not going to go down, so you don't really need to worry about monitoring the CBC, which is great. However, increased risk for infection, increased risk for TB. So again, you got to test beforehand. Okay. In some cases, you may actually have patients who, when they develop an infection, need to discontinue therapy, so that way they can kind of clear it, and kind of get back on the therapy. But what do you think happens if you were to discontinue one of these in the middle of therapy? you see a flare-up, right? So you can end up seeing exacerbation of disease. So those are the things that to consider. Sometimes you put them on corticosteroids in order to kind of tamp that down, but again, just things to consider. And don't give live vaccines during therapy with these. Give them beforehand. So getting into the TNF inhibitors, they're all going to have similar side effects and contraindications here. The only big differences are going to usually be the dosing, how often they're given, whether they can be given as an injectable in the home or if they have to go, say, into an infusion center to get it, etc. Big things to see here. There's some risk with patients with CHF. You can see things like infliximab and etanercept can actually cause CHF exacerbations and actually are recommended to avoid if they have class 3 or 4 heart failure. Okay, so one thing to consider there. And then patients with MS can actually induce or exacerbate symptoms, so you want to be careful in those patients as well. Okay. And again, black box warning for lymphoproliferative cancer. It's a relatively low risk, but it's something they have seen. But again, you're weighing the risk versus the benefits, right? That was a consideration. So the first one we have here is etanercept. This one actually is kind of interesting because it's binding the TNF by looking like 2 TNF receptors kind of linked together. So instead of being like a true antibody, these are basically 2 of the receptors kind of attached together. They'll bind up TNF. And once it's bound up, then it's kind of inactive. You can't really do anything at that point. So very fast acting, within a few weeks compared to your non-biologic DMARDs, and just very, very effective for the most part. So oftentimes either given by itself. So you can see the biologics by themselves, or it could be given with something like a methotrexate to get sort of increased efficacy there. Okay. And again, I'm not going to ask you the dosing specifically, but I'm just trying to illustrate some points here to look at the cost of these and how they're given. So like this one's given as a sub-Q injection twice a week. That's good because patients can give it themselves at home potentially, right? Now, can patients give themselves IVs at home? Not generally, right? If they are, they have a skill set, which I'd be curious to see how they got that skill set in the first place. They're very good at giving themselves IVs, but yeah, again, risk for infection and the cost is going to be pretty high, right? So about $15,000 a year. Again, not as high as something like Hep C or something we're going to see a little bit later on, but definitely pretty costly. And again, though, does it make sense for the insurance companies to cover this? It does, right? Because again, if I can keep them out of the hospital, our hospital stays very expensive. 100%. You got to pay all the nurses, you got to pay the doctors, you got to pay the PAs, the pharmacists, everyone else, right? You got to pay everyone. So again, you're going to find that if you can keep them out of the hospital, that's generally in the, beneficial for the insurance companies. They're going to usually end up paying for at least one of these agents. You'll find that depending on the insurance, it may find the ones preferred over another, etc. In fact, in some cases, we actually have the drug companies have programs set up just to help patients get onto these drugs and get them some kind of payment program or get them some kind of access to it. So for instance, we have a program over at Nemours where the Humira people give us free Humira, which is great for us because then we don't have to pay for it, right? We give them the first dose in the hospital, and then they work with the patient once they get discharged to continue therapy, right? So again, it's beneficial for the drug company because again, they have someone who's going to be hooked on that stuff for life, right? The first dose is free, then you got to pay. But they can work with the insurance companies and try to make sure they actually stay on the therapy there. So again, there's different programs you may find. Anyway, infliximab is another one. This is Remicade. Now, anyone remember what that X means? It's chimeric, right? So you can incorporate human and mouse protein. What's the adjective for mouse protein? It's murine, right? Murine protein. I think it's an adjective, right? My grammar correct? I don't know. Anyway, but it's murine protein. So what do you think that means as far as potential side effects go? Anaphylactic reactions, right? So again, this is going to be much more so than you would see with something like adalimumab. So because of that, you have to think about the anaphylactic reactions. Now, it could occur with any of them, right? Because again, foreign protein. However, it's more of a risk with this. And so again, when you're ordering these things, think about the other medications you need to order to have on hand. So what would you consider? Benadryl is a good one. So antihistamine. What else would I have on hand? Corticosteroids might have like hydrocortisone or methylprednisolone. What else? Epi, right? So again, I'd have on-call orders. So that way the nurse can go and give the med if in case they do have a reaction. Some patients get pre-medicated too, though, right? So for some patients, especially with infliximab, we'll give them a pre-medication dose of, say, Tylenol, because you may get a little bit of fever and kind of some chills associated with that. We'll give them Benadryl beforehand. Okay. Some patients even have to get steroids beforehand because they have a known reaction, but this is the only med that works for them. Okay. These are things to consider. Anyway, so it's binding up that TNF. This is an antibody itself that binds up TNF, inactivates it, and very good for patients who maybe have not responded well to methotrexate, something like that. Very, very useful in combination as well, so that can be another benefit there. And again, sometimes what we do, and again, because we're injecting a foreign protein, what could potentially happen if we keep injecting that protein and we keep re-challenging the patient with that drug? What could happen? You get resistance to the medication. Why is that? I get antibodies to the antibody, and it may no longer work. So what I could do is give an immunosuppressant along with it to maybe prevent that from occurring. So sometimes by giving methotrexate along with it, you kind of stave off that reaction from happening, and the drug will stay effective for longer. Right? So little things you can try to do, try to keep the drugs active, because again, this is a lifelong kind of disease state. We want to make sure that joint stays effective as long as we can, and try to stave off that disease progression. Because again, when you have a 6-year-old JRA, that's a long time they're going to be living with that, right? So we want to hold off on that. We want to keep our drugs as active as long as we can. Okay, and again, usually these products, because they're proteins, have a longer half-life, so say every few weeks or so, maybe once a week or twice a week. So generally, not an everyday sort of medications you're going to see here. And this is good because the patient comes in maybe every 8 weeks once they're stable to the infusion center. You don't have to think about it too often, right? So compliance usually is a little bit better from that standpoint. And again, we talked about how to manage those injection reactions, so you guys know that already. Again, the infection risk is going to be big with this one as well. Okay, adalimumab, functionally not a whole lot different than the infliximab. The anaphylaxis risk is less though, because again it's more human protein. That M generally means it's more human-based protein there, which is great. So it looks more natural to us. We don't have a reaction to it quite so much. And again, it comes as a pen, so a patient can inject themselves at home, and they give it, say, every other week. So again, sometimes it may be useful to have reminders for them, make sure, hey. Because again, I can't barely remember to do something one time a day. So if you told me to do something every 2 weeks, I have a hard time unless it's on the calendar, right? So things like that are things to consider. Again, same adverse effects you can see with this. Risk for infections, it's a black box warning for this one. Headache, pruritus, nausea, vomiting. A lot of that's related just due to an immune reaction to the drug itself. Batacept, again, this is usually going to be one that's going to be better for more moderate to severe disease, or I guess severe disease, as I mistyped here, who've kind of failed other therapies. This is going to be a good one for them to go to. And it's actually what we call a co-stimulation modulator. You want to say modulation, what does that normally mean? The fancy word for saying we don't really know how it works, but this one we do know somewhat. So you say, oh yes, it modulates the prostaglandins, and this usually means we have no idea. But anyway, so it binds the CD80 and 86 receptors, and by preventing the interaction there, you prevent them from kind of binding up the antigens, and then you can't necessarily have that T cell activation occurring there. Okay, so basically preventing the T cells from getting activated by binding up the receptors that would normally bind to the antigens in the body, which is our natural proteins we're producing, right? Again, oftentimes given in combination therapy, again, patients who have failed tumor necrosis factor therapy with adalimumab or infliximab, this is a good one for them to go to because they typically do respond to this. About 50% of those who fail TNF therapy respond to this drug here. Again, similar reactions. Rituximab is one. You actually sometimes will see this used for certain cancer treatment, certain types of leukemia. This is, again, another chimeric one, so the anaphylaxis risk is a big one. However, this one's going to be specifically bound to CD20. So it's targeting the CT20, these B lymphocytes, and so by binding that, you're going to cause a big depletion of the B cells, so very potent anti-inflammatory because we'll get rid of almost all those B cells, and will basically decrease the amount of antigens that are being presented to T cells. That's not happening. T cells don't get activated. So that's basically how it's going to be working there. And this is a problem because even if you stop therapy, it could be a while before the B cells kind of replete themselves, and so you can be immunosuppressed for quite some time on this one. And again, not usually used as a first line. They've usually failed other therapies or moved on to this one eventually. It's very likely to see some reactions to this one, so we oftentimes will get Tylenol, Benadryl at the very minimum before they get rituximab. Usually we'll get some steroids beforehand as well because we know they're going to have reactions to it. Okay. Another popular one is going to be tocilizumab or Actemra. This one's actually going to be a monoclonal antibody targeted against IL-6 or interleukin-6. And again, just going to be overall anti-inflammatory by decreasing that interleukin activity. It's going to decrease that chemotaxis, etc. And so typically they failed TNF blockers. This is what they're going to be going to in a lot of cases as well. And so I see quite a bit of this being used over at Nemours nowadays for some of our kids there. This one's only notable by the fact that it can induce CYP3A4. Be aware of that because it can drop levels of other drugs, right? So again, if you, for instance, have a patient on birth control, it's not great because again, you're going to find the estrogens are metabolized through 3A4 in the liver. So if I induce that, estrogen levels will go down, and then they can be potentially at risk for developing pregnancy, right? Statins can be affected, right? Which statins could be safe with this? Rosuvastatin? Atorvastatin is actually 3A4 additionally, right? It's like fluvastatin, I think was the other one, big one, but rosuvastatin is the go-to non-CYP3A4 mediated statin there. But anyway, again, very similar reactions to a lot of the other ones. Kind of unique one, the GI perforation. I've never seen this, but pretty rare risk, but it could potentially happen. Okay, so with the biologic agents, you're going to find that in some cases, you're going to find that we have what we either call a primary or secondary lack of efficacy. The primary means after 3 to 6 months of therapy, you don't see any additional benefit, or you don't see really any benefit in the first place. This is going to be primary lack. Secondary lack would be if they get an initial response, but then it kind of tapers off over time. That's usually either due to the body generating antibodies against the drug itself, those proteins, or the disease progression is occurring and the drugs just aren't as effective anymore. And a lot of patients just quit because of side effects, right? So again, either due to hepatotoxicity or whatever the case may be. In these cases, you may need to add on a non-biologic DMARD in addition to the biologic. So again, that's a good combination there. You get pretty good synergy between those two, but you never want to use combinations of 2 biologics together. So no Xeljanz along with the biologic and no 2 biologics together. Just way too much risk for infection in those cases. It's not going to be beneficial for your patient. And there's corticosteroids, right? We always like corticosteroids. What are some good options for that? Good drugs to use. Prednisone's a good one. What else? Prednisolone, which is a liquid form of prednisone. Dexamethasone, what's a good IV form? Methylprednisone's a good one. Hydrocortisone could be used potentially, right? IV hydrocortisone. So different options that are out there. Again, very good anti-inflammatories. Some patients are going to need to be on these on low-dose corticosteroids every single day, but the goal should be to what? Have no corticosteroids on board, right? But again, if these patients are taking it long-term, what do you have to consider doing once you try to get them off of it? Got to taper, right? Because again, what do you put them at risk for? Adrenal insufficiency. Okay, they're not going to be able to regulate their blood pressure. They're not going to be able to regulate their glucose. It's going to be bad, right? You don't want to put them into adrenal crisis. So again, these are going to be long-term corticosteroid users. You got to taper them off if you're going to try to get them off of it. More often than not, they're going to stay on it long-term, and then you have to give them boost doses or kind of pulse doses of steroids when they have exacerbations. Okay, and again, when they're going back down to their normal dose, you can taper off over a couple of days or so to get them back to their normal dose, because again, that's what their body is now used to. Okay, so things to consider. Again, with some patients, every other day therapy can be used, but a lot of times you find that's not really going to be that effective. If they need it, they need to be on it every single day there. And in some cases, we'll consider using this as bridge therapy. When I say bridge therapy, what does that mean?
Use it until the other stuff works.
Yeah, you're using it until something else kind of starts to work. And we mentioned for things like Methotrexate, things like the biologics, they can take some weeks to months to really kick in. So I can start them off on corticosteroids, which I know we're going to work pretty immediately within hours to days, and I can bridge them until I get the other drugs starting to work, then that's going to be more effective for the patient overall. Try to get those symptoms into relapse there. Also very good for disease flare-up. Oftentimes we're going to be using parenteral routes, either intramuscular or IV for those flare-ups that occur there. If it's going to be for more chronic dosing, oral is going to be totally fine, right? And again, if it's longer than a week, you got to taper them off, so consider that. And then in some cases, we can use intra-articular injections. Now, what do you think the bioavailability is systemically of an intra-articular injection? Pretty low, actually, yeah. So the joints are pretty well spared from that systemic circulation. So because of that, I don't need to worry about as much as systemic immunosuppression when I just inject into the joint, which is a benefit, right? Because again, I don't have, what other side effects do I worry about from corticosteroids? You can see cataract formation can occur.
Weight gain.
Weight gain, yep, for sure. Edema, hyperglycemia, changes in mental status, all kinds of problems, right? So we know all the osteoporosis, all these issues we know. So that's why if we can just shoot for, say, one joint, right? If we can inject into one joint, that can be very beneficial. If it's more diffuse, if there's a lot of joints being affected, you need more systemic therapy there. Now, one thing to note is that you don't want to do more than 2 to 3 administrations of corticosteroids intra-articularly a year. They actually end up find things like tendon atrophy and actually worsen joint destruction when you give it too frequently. So only 2 or 3 times a year they can get this. It's very effective while it lasts, but then eventually it's going to taper off. You're going to be right back where they were before. Okay. Obviously, the lowest dose possible should be used. And we do know that it's effective. You can slow down progression somewhat, but not going to be as effective as like your DMARDs and whatnot. However, look at the adverse effects. I mean, there's so much that's going to be associated with it. They're very effective, but very toxic over time. Okay. And again, these are going to be, think about like, side effects with someone who's getting, a 5-day course for asthma. You don't see a lot of these long-term issues here. You don't see the osteoporosis. You don't see the cataracts, etc. This is where you're going to see that in these type of patients who are chronically inflamed. They're going to be chronically suppressed these corticosteroids. You're going to see a lot of these issues pop up. Okay. We talked about NSAIDs. We talked about these previously. How do they work? Like cyclooxygenase. Now remember, there's COX-1 and there's COX-2. Which one is always around, always expressed? COX-1, right? It's very important for what? For the stomach line, right? It helps to keep that gastric barrier up and protects our stomach, right, from being digested by our own stomach acids. COX-2 is what? Call that inducible. That's being induced when you have inflammation occurring, right? So for RA, COX-2 is going to be kind of over ramped up all the time, essentially, right? Because you're always inflamed. COX-1 still very important though, because you need for that gastric barrier. Okay. So now we talked about COX-2 selective agents before. Kind of mentioned them briefly. Which one do we have as kind of a good go-to COX-2 inhibitor? Celebrex is like the biggest one we have. Now, is that completely COX-2 selective? No. What happens if you do that? Heart attacks, stroke potentially, right? So we don't like that. And again, keep in mind what type of patient is going to be good for what type of NSAID. If I had someone who has a high-risk GI history, maybe a COX-2 selective agent is going to be a little bit better for them. If I had someone who had a recent MI 6 months ago, probably not going to, I'm going to avoid that, right? What can I give in addition to an NSAID to try to prevent that GI toxicity? Methotrexate, right, which is a prostaglandin. What else could I do? PPIs, right? What's an example of a PPI? Omeprazole, what else? Pantoprazole, esomeprazole, right? That'd be good. What if I couldn't use a PPI? H2 blocker, right? Not going to be as effective, but could also be used as well, right? So there's some ways to get around this, and just be aware. And every patient's a little bit different. There's lots of shades of gray out there. A lot of times students get hung up on this COX-2 thing. I don't know why they get so hung up on it, but you guys just latch onto this one and you go down fighting like, well, this person said this about this COX-2 inhibitor, and they said it's okay for this type of patient, but not this type. Just know, in general, you're hedging your bets a little bit, right? If they have a high GI history, high-risk GI history, COX-2 is going to be a little bit better for them. If they have a high cardiac history, you're probably going to use non-selective in general. If they have both, I'm going to try not to use an NSAID if I can, but I'm going to try to use non-selective and use something additionally to try to help protect the stomach. Okay. Okay. So again, typically NSAIDs, as far as bottom line goes, we've covered these before. They're going to be adjunctive therapy to analgesics in osteoarthritis, or sometimes they're just used by themselves, right? Because again, what type of patients do I also want to be considerate of when using NSAIDs? What type of organ toxicity do I think about? Think about renal toxicity as well, right? So if they have renal dysfunction, they may be really dependent on those prostaglandins. They're going to lose that when they're on these NSAIDs here. Note the NSAIDs do not modify the disease progression. These are only for symptomatic relief. They don't stop joint destruction here, okay? So again, you can have a patient who may go off of NSAIDs for a period of time, but they may not ever go off of their disease-modifying therapy, right? Because again, the difference there is you can help to delay that joint progression here. If they're not having a lot of pain symptoms, NSAIDs are not really all that useful at that point, okay? It's okay to use aspirin, like low-dose baby aspirin along with NSAIDs. That's totally fine. Because again, as soon as the NSAIDs are out of the system, are they going to have antiplatelet effects? No. So if you're using for cardioprotection, low-dose aspirin is still fine to use with these. Just know that there could be a small risk of increased side effects there. Okay. Again, so we've covered this. So again, COX-2 inhibitors better for high-risk GI patients. Okay. Right. So it's just kind of the standard slide. So I'll try to use this and point students back to the slide. Here's what you need to know, but I always have trouble with it anyway. I don't know. Okay, so looking at an algorithm for rheumatoid arthritis, how you would manage these patients here. So again, starting off, you say you have a DMARD naive patient. They're like, what's a DMARD? They're naive. They just haven't received it before, right? Anyway, so you either have low to high disease severity. Depending on that, you're going to look to see, like, okay, well, let's try to get them started off on a DMARD. And maybe start them off, depending on how bad the symptoms are already, start them off on prednisone, right? Because again, that's going to help that be used as bridge therapy. Decrease the acute inflammation to get them down to a baseline, and then that the DMARD will start to kick in. Methotrexate is generally going to be your first line, okay? So if I did, go ahead.
Do we use this for 2 months because it's going to take 1 to 2 months to get activated?
For the corticosteroid? Yeah, you could be prescribed, yes. You may give them a couple refills, and you say take once a day, 1 tablet daily. For give them like 3 refills maybe, right, to see how they're doing on that. So you're letting the methotrexate kind of kick in. Again, that's typically going to be your first line. So if I asked a test question, I said, you have a new patient just diagnosed with rheumatoid arthritis, have their prescription for prednisone. What's a good first line DMARD? They have no contraindications. You're going to say methotrexate's a good one, right? So looking at that, say they still are having pretty high disease activity here. What could we do at this point? Well, I can either use combination DMARDs. So what can I use? I could use methotrexate plus hydroxychloroquine, maybe if it's a little less severe. I could use sulfasalazine plus methotrexate. Like I can use combination of the non-biologic DMARDs, or I could use a biologic plus methotrexate, right? So again, depending on if they got no benefit whatsoever from methotrexate, maybe switch them off of that completely. Or if they got good benefit, but maybe not as much as you would like, do methotrexate plus something else. Okay, you can use the TNF alpha inhibitors typically first, so either infliximab or adalimumab. Those are usually going to be your first line biologics you're going to be jumping to. Or you can consider something like tofacitinib plus methotrexate. Right. This is the newest one. We don't have as much history with this one as well. So again, depending on the provider, you know, maybe when's the last time they had the drug rep come by and give them dinner, they may be more likely to do this one versus a TNF blocker. It just depends, right? So again, you're going to find that this may change over time. What's going to be kind of the recommended is really the big first line one. And again, a lot of these patients are going to be very heterogeneous to one another, so it's hard to say this patient may really respond well to this version or this kind of combination versus they might respond better to this combination. So we don't really have good guidance to say which one to do first. But looking at this, if they have a single, let's say they have a non-TNF biologic failure, this is where you can try using up either another non-TNF, so either like, you know, say a etanercept or switching over to say like tocilizumab, you know, plus or minus methotrexate, and then just can kind of continue on to see, well, let's try a TNF alpha inhibitor at this point. If they have a TNF alpha inhibitor failure, then you'd say, okay, well, let's use a non-TNF biologic. Okay, so if I ask a test question, I say patient's been on methotrexate plus infliximab, but they're failing therapy, what would be a good biologic to switch them to? So I may say something like, you know, the correct answer may be something like, you know, rituximab, or it might be etanercept or something that's non-TNF based. Okay, so you know what the target they're shooting for with all those biologics. So I know the difference between interleukin versus a TNF alpha inhibitor versus, you know, a CD20 receptor, you know, target, things like that. Those are the things I kind of want you to know the difference, so that way you know which ones to switch to. Because again, you wouldn't want to go from infliximab to adalimumab, because those are both shooting for the same target. It really wasn't that effective in the first place. Why would you go ahead and do the same thing over again, right? Makes sense? Now you may have to switch a patient, say from infliximab, it's working really well, but the insurance company changed, and now they won't pay for that. They want to use Humira. That makes total sense as well, right? Because if it's working for them, Humira should be working as well, right? There shouldn't be a whole lot of difference with that one. That makes sense? Okay. Anyways, that's generally what you're going to be doing. Again, looking at combination of traditional DMARDs, you know, non-biologics, they go very well together. You can use a biologic plus a non-biologic, that's fine, but never two biologics together, right? And no tofacitinib plus a biologic. You don't want to do that either. Typically, methotrexate and leflunomide you want to avoid because they have a high risk of hepatotoxicity. So that would be one combination you want to be cognizant of, right? Okay, and then we talked about the biologic plus traditional, so I won't belabor that point. And then that's going to be it for the rheumatoid arthritis drugs we're going to be talking about here. Okay, so that's all I'm going to cover for today. I'm going to check the board real quick. Basically, what we're going to do next week is we're going to finish up this section. We're going to go through the behavioral stuff up until through the end of antidepressants, and that'll be the end of the test material. And I think your test is that next week, correct? Sounds about right. Okay, let me check the board. Let me see.